Good afternoon. My name is Katie Mason, and I am pleased to welcome you to this Establishing Virtual Group Clinics webinar. I'm now pleased to introduce you to our webinar host, Maggie Bradley, Queen's Nurse and Clinical Nurse Lead for Sefton Training Hub and Southport and Formie Health.
Hello, everybody. Thanks for joining us. I'm here this afternoon to tell you about my journey using video group clinics, so virtual clinics, as it's been called. I am from primary care, and I'm conscious that quite a few of you might be from secondary care, but to be honest with you, it really doesn't matter. It's easy to make it work in either setting. So I'm just going to share with you my experience of setting them up and what they are, and what some of our patients think of it. And also at the end, there's a couple of minutes of a video that I recorded actually for our patients to get an overview of how they felt about joining and what they think about it in general. So that's going to be up at the end. Obviously, as I said at the start, this is about my journey with using video group clinics, and I am in primary care. But as I said before, you can literally make this work in any setting whatsoever. So I'll just start off by telling you what a video group clinic is. And it is a group of patients that have a similar health condition. So for us in primary care, it was a group of diabetics, a group of asthma patients, a group of people with a cancer diagnosis, a group of postnatal women, for example. And what we do is we have 6 to 8 patients on a call. And we have a facilitator who does essentially what Sarah's been doing today, in that they send invites out and control the sort of the sort of proceedings on the day. So they send all the invites out, help with all the technology of people joining and one thing and another. And then I obviously do the clinical reviews. So it pretty much can work anywhere. So that's what it is in a nutshell. And as we go along, more information will become apparent. And if at the end you want to ask questions about the actual setup process, that's fine as well. So this all kicked off really for me at the start of COVID. So we had done the odd clinic in the surgery with a group of patients when they were allowed to come in face to face. And that worked. That seemed to be working pretty well, actually. And then, of course, COVID came, and it was a case of, it seemed like anyway, almost overnight, the doors shut. All of a sudden, we couldn't see our patients and they couldn't see us. And for us nurses in primary care, one of the biggest things that we achieve in our everyday work is building up a relationship with the patient. And that's how we that's how we get any sort of health results, for want of a better word. So it's how we make any changes or how we, engage with people. It's just about that relationship. And it did seem like there was nowhere for that to go. And it just seemed like, what on earth would we do? And for me in primary care, I thought, well, there's no role for me. I might as well jump on a train and head off to one of the Nightingale hospitals and go and work in secondary care again. That was how bad I thought it was, because I really couldn't see a role for us within primary care. Anyway, so training came around, and training for this new thing, video group clinics, was one of the things that came. And I'll be honest with you, I'm not, as you probably gathered, any bit technical or digitally minded whatsoever. But I saw this opportunity and I thought, I've really got to go for something like this, because it's something different. It was a way that I could see patients and a way that they could see me. And it was, apart from anything, a way of connecting with patients. We felt like we couldn't connect with them. We were sort of doing a lot of telephone stuff, and it just didn't feel the same, and it just wasn't the same. So straight away, our little team, there was myself, one of the reception staff, and the practice manager. We did the initial training, and then we rolled it out to our sort of little team. And we are only a small team. We're a general practice, so we've got about 6,000 patients as a list size, which is pretty small compared to others. But as I'll show you as we go through, this model, it can be transferred to any setting, really. So that's how it all came about. And the alternative was seeing people in this way. So Sarah, can you just show the next slide, please? So obviously for me and for us, there was no way that the old ways of working were going to be able to carry on. We couldn't carry on doing people and seeing people in the same way as we had done before. We literally had to think of something different, and this was the something different. So we did embrace it. And I'll be honest, I've never used Microsoft Teams or any sort of platform like that. To be honest, I'd never heard of it. Not many of us had in our setting. And of course, patients hadn't, because if you remember, it was back in 2020 and patients weren't that familiar with stuff like this. So it was really quite something to get it off the ground. In terms of me as a sort of technophobe person, to reach outside of my own sort of barriers of, oh, I can't do it, I don't want to see myself on a screen and all of that, and then to convince our practice team that they needed to come on board. And that's one of the things that probably would be a challenge to anybody, including yourselves in whatever setting, is you might think it's a good idea, but it's about persuading others that it's a good idea. And one of the biggest resistors to our idea was the actual reception staff. So again, I'm sure we've all come across reception staff as patients within our own GP surgery, and they can be quite forceful and quite tricky at times, to say the least. But one of our biggest challenges was getting them on board. And I can still hear now the reception staff saying, it'll never work here, Maggie, total waste of time, that absolute waste of time. Our patients will never like that. And sure enough, when I got those people on board, showed them how it would work, showed them what the patients could get out of it, these people really came on board with me and ended up being like part of the little team that ran these events. And one of our biggest advocates now is the person who was most resistant to it. So that might be something, to think about within your own teams, of try and conquer the people that really are resistant. Because if you can conquer them, you can kind of conquer anybody. So we very much did that. We championed this new way of working. And when I put there that we pushed through our own personal boundaries, that was probably the hardest, I must admit, because I was convinced that, I couldn't talk on a screen like that, and I needed to see people face to face, and I couldn't really make that transition in my own mind. But you've just got to, you've just got to give it a go, really, and embrace it. So we did 2, which were with our families, believe it or not, to give it like a dummy run, if you like, a trial run. And we had our families all pretending they had asthma, and we, sort of work through it with our families. And, equally in secondary care or whichever setting you're in, you can use your practice, your team to have a go at it. And it makes it a lot easier when you've had some trial runs. It definitely helps solidify it in your head, because until that point, the idea is there and it sounds good, but then you actually need to do it to actually see how it runs. And so then we took the big brave step, obviously, of inviting some patients. And the way we did it was we engaged with them and were really honest in saying that this is a new way of working for us. We're not sure. We're giving it a go. We hope that we'll be able to reach you and, do something for you, and invited them to come on board, really. And our patients really did, some didn't, not all did, but some of them were like, yeah, I might as well give it a go, let's see how it works. Let's see how it works. Obviously, a lot of people were using Microsoft Teams by then in their work. So a lot of people were really, really savvy with Microsoft Teams, such as, we had like young men with asthma who were out working. They'd used it before. So they were a great resource when we did their sort of asthma reviews. They were, helping us. And the patients were very understanding. And very soon it got to be almost a normal way of working. And we sort of changed it as we went along, as I'm sure you will for your patients, in that if you involve the patients from the start, they're really, really good at telling you what works for them and what doesn't work for them. So, for example, when we started off, we had quite a long consent process. And now we've managed to make that a little bit more slick. So we don't need to talk as much. We can send stuff out to the patients beforehand. We spent a lot of time helping people with technology at the start. And that was great. People very quickly adapted to that. They were seeing their families on Zoom, ordering their shopping, weren't they, online, Amazon and such things. So people were quite open to giving a new way of working a go, really. So we very much always involve the patients, and I would say that is a key, really. Try it with one group. If it doesn't work, try a different group, because within that you'll get people that it really, really suits. Okay, next slide, Sarah, please. So we think that it's really, really innovative, this, because we've adapted this model of working as a new way of seeing patients. So as I've said before, we had technology. I don't know about you in your setting, but for us in primary care, all of a sudden there was laptops coming out of our ears, and you know, we were doing stuff remotely. I would never have dreamt of doing that, you know, years ago, or even a couple of months before COVID hit. So it was definitely a case of learning on the job. So we did use that technology. And one of the things that we did, which I think is quite innovative, is that we use student nurses as part of our team to help us. One of my job alongside my practice nursing job is that I'm passionate about opening GP placements for student nurses in particular. And there's quite a lot of resistance to that in general practice. So this was a new thing, a new way of working, and also a new way of engaging with student nurses. So we had 3 student nurses come out with us and work with us on this project. And it was absolutely brilliant. If it wasn't for them, there's no way it would have worked. They were so inspirational. They had fantastic ideas. They had great different ways of communicating, different ways of seeing things. They had the heads up because they were social media experts. So they took care of our social media. They got our surgery a website and Instagram and a Twitter account. And so we were able to share what we were doing with the patients. So they were a great inspiration to me personally, and also to our team, because quite often when you set about doing things in a different way, it can be quite isolating. And sometimes you do definitely think, oh gosh, is this worth it? I mean, it so is worth it, but you just have those times where you think it isn't. And then it's really helpful then if you've got other people that can pick you up and, you know, help you along. And the student nurses definitely did that. And as well, hopefully, it was a way of showing them that we are forward thinking in primary care. We can do things differently. We can think differently. We can think outside a box, and we can embrace technology. So we definitely did that. And we were able to prove that we could see people all different times of day. So no longer were people stuck, restricted to the primary care opening hours, which can be a bit tricky for some people to access. So, we did evening sessions, we did weekend sessions. We did them at all different times of the day to suit the group of people that we were dealing with. And it also helped that people could join from anywhere. So, for example, when we did our cancer video group clinic, so we had a group of patients who were all relatively recent cancer diagnoses together on a video group clinic, and we were doing their cancer care reviews. So we had somebody join from a chemotherapy session, and then we had somebody equally joined from a van who was working in London, just jumped in his van and was able to join us. So it's definitely helped us engage with groups of people that we wouldn't have engaged with before. And, I was in my head, I was one of these people that thought, oh, older people, they're never going to be able to use this, never in a million years. And it's been such an eye-opener because those very people really, really embrace it. So many of them have got smartphones, iPads, they're seeing their families on Zoom, and they were really, really all prepared to give it a go. And of course, we were always there as well. The facilitator was to help with that setting up of it. And that's another thing you might find. Some of your patients are quite, I can't set it up. I don't know, I'll press the wrong button and this sort of thing. And, it's about having the people there to support them in that. So now if we get anybody like that, we bring them into the surgery with their iPad and we're able to show them. But before that, when we couldn't bring people in, we'd call them and talk it through, because yourself, it can be quite onerous when you've never used the technology before. Okay, next slide, please, Sarah. So, it definitely brought us to get all of us together because we had to all work together. So we had the clinicians, which, was sort of led by me, and you'll have different clinicians in your organizations, and some will want to give it a go and others won't. But also we had the support of IT because we had to, as I say, all these laptops appeared, and we had some, quite good IT support. We had Health Education England, who also were the ones who rolled out the training and commissioned the training. So that came our way in terms of that. And we involve people from the third sector and voluntary organisations very, very much. So as I've given you the example of the cancer video group clinic, we have Macmillan, the Macmillan support team, join us on that, which was amazing because at the time, there were no, organisations like Macmillan and everything like that had closed their doors as well. They were doing virtual stuff as well, but it was difficult for people to access. We also had a Move More team, which are a physiotherapy team, and they help people on chemotherapy. So they joined us, and we're doing a series of long COVID video group clinics at the minute, which I'm sure many of you will have come across, and obviously us in primary care, we are seeing more and more of. And so we've engaged with the local long COVID service and the social prescribers to join us. So for example, tomorrow we have a video group clinic for our long COVID patients across our primary care network. So we have rolled it out on a bigger platform, and we'll do long COVID tomorrow with a focus on respiratory issues. And those other people will be engaging with us on that so that the patients can actually access those services that they might otherwise struggle to, or there might be a long waiting list. So we've done diabetic clinics, we've done asthma clinics, as I said, we've done every sort of long-term condition that we can, we've done in this way. And it's really, really proved successful for the patients. And I'll just give you a brief outline of how it looks. So obviously when we join, we do consent. People get consent forms. They provide us with a safe word. We explain how the procedure is. Everything is recorded within their notes. Our facilitator covers all of those things. And then when the actual group set starts, then each person has an individual 5 minutes with the clinician. So as well as an overview of a conversation where people learn from each other's, different issues, there's a one-to-one opportunity for the patient to be with the clinician as well. And quite often what I've found is that when you have that one-to-one with the patient, then the next patient says, actually, that's exactly the same as what I'm experiencing. And they learn in that way. And then that often sparks a conversation then. So that's briefly how it sort of runs. And then at the end, of course, there's goal setting that goes on with the facilitator, and resources that we could send out afterwards, which we do plenty of, and networking, of course, that we do as well at the end of the clinic. So it's a very easy way on for us to review our patients with long-term conditions. Okay, Sarah, next slide, please. We definitely think we've added value, and I've given a bit of an example here of an asthma clinic. So for us in primary care, one of the groups of people that is the most difficult to engage with asthma are men in the sort of 40s, 50s, men that perhaps are working, men that don't think it's an issue, asthma, and they don't need to come for a review. They're very, very difficult for us to reach out to usually. And this just suited that group of patients really, really well. So, we do like a video group clinic for about an hour, and then we could review 6 to 8 patients. And if I'd have seen them face to face or, on a phone or anything, I would have taken me 20 minutes plus. So there was definitely a time saving in terms of time. And to be honest, I know that there'll be a lot of people looking at time savings and things, which is important, obviously. But the best thing for us as a nurse or as a clinician was just seeing the patients. That was the best bit. It's amazing to see their faces, and they were delighted to see our faces. And that was really something that I hadn't really expected. And I was wondering about things like, would I be able to see people's inhaler technique and this kind of thing? And obviously this setting lends itself brilliantly for that. So I don't know what, anybody in primary care will back me up on this, that so many times patients come to these reviews and they've left their inhalers in the car or at home. You can do a bit of a demonstration in the hope that triggers something, but you really need to see the patient taking the inhaler. And I found that this way was brilliant, because even though they said it was upstairs or wherever, they'd run upstairs and get it. And we could share inhaler techniques. And actually that was one of the biggest things that people learned, was inhaler technique from other patients, because as we all know, you can tell a patient until you're blue in the face about things. And very often they take a small amount of notice, but if they hear it from another patient, then yes, it just seems to, make so much more of a difference. So we think by that we did improve the quality of the review. They didn't have to come in. That saved them time. It seemed to be much, much more convenient for people to take 20 minutes, 20 minutes, half an hour out of their day to do a review, rather than having to take much, much longer to leave work early, trundle into the surgery, possibly wait and all that kind of thing. So we're really happy with the way that part of it went. Next slide, please, Sarah. So it's very, very adaptable. Lots of nurses contact me now and ask about, how we did this, and do you, how you go about it, and how does it work, and how does it look? And I'm more than happy to share that with people, because I was a bit of a nervous wreck as well at the start. So I totally appreciate that other people might be. And it can be used in any setting, like I've said. So, secondary care, it probably could easily be adapted to that. And we've rolled it across our PCN. So for those of you who aren't in primary care, a PCN is a primary care network. So it's a group of practices working together as one, and sharing targets and things like that. So this is a perfect way to be able to work across different surgeries and meet the needs of the primary care network, which is the way for us in primary care. Things are certainly going at the minute. It's very, very flexible, like I say, any time of day or weekend, whatever, to suit the group of people that you're trying to reach. It can be done with those groups of people. Next slide, please, Sarah. And it's definitely sustainable. We have, as I say, we've rolled it out. We've gone to our PCN. Our student nurses made a sort of a playbook about how you can adapt it to different scenarios, top tips, that kind of things. And there are more formal toolkits available on eLearning for Health. NHS England also have sponsored that, and that's on the eLearning for Health platform, and that can be accessed by most of us with an NHS sort of login. And I think I've said this already, the patients for me are the biggest thing in all of this. And as a nurse, it's just fantastic to be able to see those patients, and they are crucial to it. So we have involved them from the beginning. At the end of everyone, we send a little questionnaire out. We get testimonials from them. We hear what they think. How they think is it worth doing? What can we improve? What went well? What didn't go so well? We kind of do that at the end of every session, for them and for us, to be honest. We really do feel, and patients have told us this, that we've reduced anxiety and feelings of isolation, and we've definitely built up a support amongst patients. And that was very, very relevant and obvious in the cancer group, where patients were literally expressing their concern for each other and wishing each other well as they went onto the treatment, and asking each other how they were. And also in the postnatal group was phenomenal. The amount of support that new mums got from other mums in different situations, or mums who had a bad experience, or mums who were struggling breastfeeding or bottle feeding. All of that went on within that group setting, and it was absolutely fantastic to see. We definitely think it's a model that you can just use and adapt whichever way you want. I mean, it's a model, that's what it is. So we've changed it for our group of patients, and you equally can easily change it for your groups. So, I am just passionate about patients. Obviously, I'm a nurse, and as I say, in primary care, it's got to be about the patients. That's kind of what we do. And our patients have very, very much embraced this. And they work for a group of people that I really didn't think would. And they really have embraced it and given it a go. I think we're going to be able to see the video now, and this is a group of some patients, all from different video group clinics. I thought that would be a better way of just showing you how good it can be. So we have a diabetic, an asthma, and a cancer patients, and you can just hear over the next couple of minutes some of their some of their stories, and it's only a couple of minutes long, and just how they found it. And I think what you'll hear is that some were skeptical in thinking, oh, I don't know whether it's going to be any good, and they were very, very pleasantly surprised.
Shall I kick off?
Go on, Roy.
I found it really positive, and unexpectedly so, really, because I think that it was very relaxed. We've had some great talks from other professionals, and interestingly, the boost I got from being supported by other people with similar conditions was much greater than I thought it would be, because
I was very skeptical of it to begin with. Not very computer literate. It's working marvelously, and considering I was so out of control compared to all the other candidates on here, I feel it's been a great benefit to me.
I found it really, really helpful to hear other people's experiences of their illnesses, diseases, situations. I found that really, really helpful, and we all kind of shared tips and experiences.
And considering I've been a long-term diabetic, I'm surprised at how better the system is now with me.
So for me, I've got 3 children, so it's a hell of a lot easier than dragging 3 children to the doctor's surgery. For instance, today I probably wouldn't have made it because I was bathing one of them at 1:45 because we had a bit of an explosion. So I would never have made that throughout the day.
It's helped me just to accept the fact that cancer's something that I've got. There's no need to not think about it, which was what I was trying to do early on.
Thanks all. Thanks so much.
Bye, everybody.
Take care. Bye now. Bye. Bye, everyone.
Okay, that's lovely. That's the end of my talk, Sarah. So if there's any questions.
Hi Maggie, yeah, we've had so many questions, so I will monitor the Q&A box for you and read them out to you, and then you can answer if that's all right.
Yeah.
So first of all, we've been asked, do you have to set up any SOPs for the meetings before you do them?
Yeah, that's a good question. The training that we did covered all of those, all of the aspects of that. So once we had signed up to the training, they showed us how to cover all of the, the elements around consent, confidentiality, and everything to do with, video insurances and this sort of thing. The surgery would have to check with the insurance company that they were insured to deliver video group clinics, and they were. And then some people took extra insurance out around stuff on the computers. And that was quite a robust process. So until all of that was in place, then obviously we couldn't go ahead. But yeah, we that was all covered within the training that we did, and the practice manager very much looked after that side of things.
Amazing. Another question is, do you have an upper limit for the numbers in the groups?
Yeah, I mean, that's been asked a few times, other things that I've done. I think it's for me personally, as I'm doing them, 8 to 10 is probably works well, because what you've got to remember is that people are listening to other people. So the more people you have in that group, people they don't disengage or anything, but naturally, if you're listening a long time to something, people can drop out a little bit. So what works best, we think, for us in primary care anyway, is about 8. That seems to work really well. I've done it with 10, people, but for us, 6 to 8 seems to work really, really well.
There's also quite a lot of questions regarding governance and data protection.
Yeah.
So someone's asked, do you have an issue with info governance and data protection? I'm thinking of the reported issues with virtual group clinics being hacked. It's never happened to me. Just wondering if it's ever been an issue for you.
No, that has never been an issue for me. I think at the start, that's why that's why, as far as I can, know, is that's why we had to use Teams and we couldn't use Zoom, because there were some issues around that. But these have all been NHS approved, NHS England approved platforms and things. So that's very much the way I've adopted that. And my practice manager very much dealt with that side of things. But I know that all that was robustly taken care of, because obviously that is a huge, big concern for people.
There is another question saying, how do you get physical measurements, BP, weight, food checks, etc.?
Yeah, that's a really good question as well. So now, obviously, we can have people back into the surgeries. So now we're sort of doing a bit of a two-way thing. But through COVID, people were sending us in their blood pressure readings, their height and weight measurements, and that kind of thing. So that was pretty straightforward to collate. And that's probably a very, very good use of this kind of resource. But I mean, if you're going to check somebody's feet, you need to see the feet. You can't get around that. So sometimes we've had to just say to people that at the time we couldn't see people's feet. Now we can. So it's a little bit different when you're doing a diabetic review. It's a bit easier. But I think you probably need a blend of both, because some things you just literally you cannot do without seeing the patient face to face. So we appreciate that. And that's what we do with our diabetic patients, is that we see them first, they have the bloods and everything done, foot check, and then we'll have their review in the video group clinic.
Another question, have you had any experience or success with groups of young people, specifically 16 to 24-year-olds?
Yeah, we've had, I'm laughing because I'm thinking of the teenagers, but we have, and it was really good, actually. Again, I thought, these teenagers aren't going to join, but they did, because they're used to this is how they conduct their school life, isn't it? On Teams and things like that. They're just so used to it. So yes, we did upper teenagers asthma reviews. And that was really, really successful. We got a lot out of that. They got a lot out of it. They were obviously very comfortable talking on the screen like this, really comfortable. So yeah, that works really well with that age group.
Which IT platforms have you used to run the session securely?
Microsoft Teams.
Microsoft Teams. There's been a few questions on that, actually. Continuing on from that question, someone else asked, do you use Microsoft Teams? Have you used other platforms such as NHS Attend Anywhere? If you have used both, which is your preference and why?
No, we haven't. When it kept for us where we are in our area, and the guidance was Microsoft Teams, so that's all we've ever used. That's got simpler and simpler as it's gone on. It was simple enough at first, but then I think they've adapted it and made it even sort of more user friendly, for want of a better word. So I think that's been the platform we've always used, and we've never had any issues. And the patients say it's pretty easy to access.
What about patient confidentiality in a group? Were you able to give individual care plans?
Yes, we were. So at the start, when we first kick off, that's the first thing we cover. So consent, and there's a group understandings there that everybody consents to, and actually writes in the chat, either in the chat or verbally, and that's recorded in their notes that they do consent to that. And that's the same for anybody joining them as well. If they've got a carer with them or brother, sister, they have to, that has to be done. And then what we do then is individual care plans are sent out after the group's finished, and we have, I can only speak for what we use in this area, but we have AccuRx. There's other different platforms I know that you can use to send care plans out. So that's how we send our care plans out after the event, and that's for the role of the facilitator as well. So while I'm doing the talking to the patients and things, they are jotting down, making notes about action plans and things, or goal setting, anything like that. And so at the end, that's part of the work that we do afterwards and send out to the patients. So yeah.
We've had another question. Are the patients able to see each other as well as you? Have you had any experience of virtual group sessions around sensitive conditions such as continuant bladder, bowel problems, etc.? And if so, did you get a good response from patients all those sessions? Sorry, there's quite a lot in that one. So the first part of the question, sorry,
Yeah.
are the patients able to see each other as well as you?
Yeah, yes, they are, if they want to. So it's exactly like joining this, although we can't see anybody. Any other sort of occasion where you join, you literally have the choice of your camera on or your camera off. And what we do say to people as well is the way your name is on the bottom there, Katie. Obviously, we say to people before they join, be mindful that your name will be on the bottom when you join. So if you don't want everybody to know your name, then put something else there. So you log on with a different name. Equally, we say to people, don't use your work one. If you're at work, use a separate one, so it's more secure. You're not got any risk of showing things that you don't want to show. But again, that's entirely up to the patient. Some patients don't want the screen on at all, and some people quite quiet and don't want to particularly say much. Other people are more than happy to have the video on, and that's really quite nice, like Sarah did when everybody joins. It's really nice that somebody welcomes people and makes them feel involved and part of it. So we love it if they have the camera on, but we equally appreciate it if people don't want the camera on. And as regarding the sensitive nature, we've done we had a urology consultant on, and he covered quite in-depth men's health things, and that was really well received. I think sometimes we think that patients don't really want to discuss stuff with other patients, but in actual fact, when they do, and if they do, they get a really good response, because those other patients are walking in their shoes, if you like. So we found that the tricky ones, can be fine depending on the patient. And equally, if there is anybody who is sensitive and doesn't want to, then we'll call them back at the end. It's not an issue at all. Just put in the chat or tell us, listen, there's things I want to discuss with you afterwards, and that's equally fine. Yeah, that's not a problem. And I just saw that question pop up about engaging people. I think who might be quiet. I think as nurses, I think we're really, really good at that, and we do sense when people are quiet, or not saying much. And so, very often I would always check in with that person, say, are you okay? Is there anything you want to contribute, or are you happy just listening? And I just think nurses are really, really well placed to pick up on things like that. So I really don't think that's an issue particularly.
Another interesting question is, how do you deal with language barriers? In London, we have very mixed languages. Another delegate has replied saying that we have separate groups for our local Bangladeshi population with translators. So I wasn't sure if you had any other response to that question.
No, I think that's right. I haven't had that experience, but other people that have had that experience do exactly that, so that they can, people can, join in, and no matter what.
Yeah, I'm also going between the Q&A box, and I've just seen there's a few questions in the chat box as well. There's a question saying, which ELFH training package do you use, and who provides the training to staff to start VGC sessions?
Yeah, so I go on eLearning for Health, and it's just under video group clinics. It's on there. There's two. There should be little animated videos about how to set it up, and contact details of people that did all the training. So that's where I'd go. I think it just sits under. I'm not sure if it sits under CPD or something like that, but it's quite easy to find on that eLearning for Health. Sorry, what was the other question, Katie? Sorry, the other part of that.
It was, who provides the training to staff to start VGC sessions? Okay,
yeah. So the people that train me are, ELC Works. They train me, and they offer training. And I think there's other companies perhaps that offer training around and about. Now, at the time, when we first went on, there was just ourselves from our little group, and we trained everybody else, if you like. But there are intensive clinics and intensive support available for people if they want it. I'm not an expert on that, because I'm at the receiving end of it, but there are organisations out there that do the training.
Another question is, I'm looking at using VGCs for cancer care reviews. I know you've used them for this. Can it work for the 12-month reviews? And these are quite long to do with patients.
Yeah, It really works well. That's what I use it for. So at the 3-month review, I do the conversation with the patient about, what should happen in the 3-month review. And then I introduce the idea and tell them about the 12-month review, and that we will offer it, in this way, in a video way. And if they want that, that's brilliant for me. But if they don't want it equally, that's fine as well. And then there's a Macmillan template, a Florey on AccuRx. I can only speak for that because that's what we use. And we send that out before our patients join us. So a lot of the information, like what you're describing, the person who's obviously asked this question, is covered in that. And that just saves you time. And it also gives you then an idea of what the questions are going to be and where to focus. So there is always, I call it a discussion board. Other people call it a results board. I call it a discussion board. And on that discussion board for the cancer care review, I would cover all of the things on that template, such as, anxiety, sort of money, worries about the diagnosis, all these sorts of things. And I'd make it quite visual for all of the patients. And that's what we base our video group clinic on then. So we can cover all that in a really, really good way. And we find that because we're not saying the same thing individually to every patient, we're using it to share. They always chip in with all of their advice. That, for me, that is one of the best ones, I must say. And if you can get anyone on, like a Macmillan support worker, or anybody like that, even better, because they field a lot of the questions that patients are worried about at that 12-month review. So yeah, it's definitely a good one to use for that.
Another question that's been asked a fair few times is, how long are the sessions? When you run them?
Yeah, like I say, when we kicked off, ours were probably over an hour. And the patients reported that was a bit too long. So we sort of got a bit slicker at doing things as well, because you get quicker, don't you? Once you know what you're doing. And so ours are less than an hour now, about 50 minutes. And then, a bit of time at the end, obviously, to write up and things like that. And it depends which group of patients as well. If you've got quite a quiet group, it's obviously much quicker than that. But hopefully it's not going to be. But yeah, that's about the time.
And as well as this, are the sessions recorded for the patients or service users to view again?
That's not something that we've done. No.
Okay. Is there a need for relatives to be present during the sessions in case of emergency, e.g., patient feeling unwell?
Yeah, I mean, that's always a good thing to do. As people join, we check that we know where they are, so that should anything happen like that, we know where to send help to. So wherever they are joining from, we know where that is. That's part of the check, before people join. And yes, it's not many times people's relatives join, particularly more elderly people that might need a bit of a hand with the technology. And that's fine, because we're all consenting to the same, for them to be there, and they follow the same rules and regulations as anybody else. So yeah, that's absolutely fine. But we do a check of, you are where you're meant to be, and if you're not there, where are you? So that if anything did happen while we were on the group, then we'd know where to send help to.
Just checking I'm not repeating myself with these questions. Another quite long one here. Was your practice offering face-to-face education groups before you moved to VGCs? If yes, have you experienced any limitations of VGCs versus face-to-face group education? Moving forward, will you be offering patients a choice?
Yeah, moving forward, I definitely want to offer patients a choice. That's definitely what it's about. It's far better that they attend whichever one they want. And yes, we just started doing diabetic ones, to be honest, before COVID came, and it was great. There's nothing like it. A group of patients all with the same thing, like learning from each other. It's absolutely brilliant. And I couldn't, apart from, obviously I'm a nurse, so I would love to see people face to face. So that's a given. But equally, there are people that just haven't got the time or the space to come into the surgery, or don't want to. So it's equally as efficient virtually. I just hope that, moving forward, we can use a blend of both so that we are actually meeting more people's needs, really, because there's definitely quite a good proportion of people that prefer to do it this way,
Another question, what have been the biggest benefits to your nursing skills?
Oh golly. Well, doing something like this, although you wouldn't think so after the hiccup at the start, but I would never ever have been able to do something like this before I started those video group clinics. I would have been an absolute nervous wreck. But so it's given me those skills, confidence skills, because I don't really ever think I'm a leader, but I obviously must have been able to lead something because I led on this. So it pushes you outside of your comfort zone, which is a pretty good thing, to be honest, as a nurse, and especially in a pandemic, because it makes you think differently about everything, what you took for granted before, like your skills of seeing, assessing, and just seeing a patient, building up a relationship with the patient. You're having to do it in a totally different way. So you've got to adapt. So I can't recommend it enough for all of those things, nursing, leading the way, showing people, just engaging with other nurses and get them to give it a go. It's just amazing. It has really changed, I'd say, the way I practice, and equally confidence in myself as well.
We have time for just a few more questions. Do you have preset Zoom times and add people into it like you might a clinic? We've not done that. We've basically set a clinic up with so many patients, and usually once it's full, it's full. That's how we've done it so far. I suppose you could do it like that. I haven't done it like that. I'm just always conscious of the numbers and and the dynamic of the group, not wanting to have too many people in there. So that's how I've done it. We have a question in the chat box which says, we tried face-to-face group consultations. The admin part was heavy, but the sessions were great. Is the admin part lighter for Vgcs?
Yeah, I think the whole thing is lighter now, because I think when we all started off, the consent and everything was quite onerous, and lots of paper and one thing and another. And I think we just got better at it now. So, things like we send consent forms out on AccuRx, we get stuff back on AccuRx, things like that save masses and masses of time, for an admin person. So, you could use tools like that even in your face-to-face video, clinics, your face-to-face group clinics. There's tons of stuff to make the whole experience a lot slicker and a lot easier for patients. So yeah, I know what you mean about the admin, but it is much better.
Do you have a care plan template that you use on, apologies for how I say this, ACCRX?
Yeah, AccuRx. Yeah. There are some care plans there, but I use the ones that are on EMIS. That's what I usually use, the asthma diabetic ones that naturally sit within those templates on EMIS. But equally, you can sort of make your own, or I'm not sure if there are care plans on AccuRx, because I use the EMIS ones, but I'm sure with the developments that seems to be the way forward now. So yeah, you can use any and just send it out electronically.
And I think we've got our last two questions. One, are the rest of the group listening to the 5-minute one-to-one, or is this done privately?
No, the rest of the group are listening. So that's probably where the most of the learning takes place, when people are talking themselves, and somebody says, well, I don't know what a HDL cholesterol is, or I don't know what this, that and the other is, and then somebody else was like, oh, I didn't know that either. I'm really glad you've said things like that. And inhaler techniques, and stuff about inhalers is the most common one. So yeah, everybody is listening, and that's why you have to be mindful of the amount of people that you've got on, because obviously the more people you've got on, the longer that process is, and people can get a bit disengaged, if you're not mindful of that.
And my final question I have here is, what were your biggest barriers that you faced?
Oh, myself, without a doubt. Myself, honestly, I really had to drag myself up there to put myself on a screen. None of us like it, do we? But it was horrendous. I thought it was awful. And, I just panicked every time the technology was there. But, that, and as I say, the reception staff, without a doubt, are, you have to get them on your side first. because everything else will go quite smoothly after that. But, you know, if you don't get them on your side, it can be a bit of a rocky road. So definitely yourself can be a barrier, but you know, the engagement of your team, that can make or break it, really. You need your team behind you.
Amazing. Maggie, do you have any last comments you want to share with the delegates?
No, just, you know, I would just say, you know, if you get an opportunity to do it, just give it a go. That's what I would say. I would say just give it a go. It's hard, don't get me wrong, but it's so worth it. And you feel it does really, really make you feel a good sense of a confidence boost, and brings all sorts of other qualities out in you that you really didn't know that you had. So I would just say to anybody, you know, tick all the boxes, make sure it's safe and everything, and then just go for it and give it a go.
Amazing. Well, thank you so much, Maggie, for delivering such an interesting webinar and for answering all of those great questions. I hope that you've all found it useful.